Management of prolactinoma. We recommend dopamine agonist therapy to lower prolactin levels, decrease tumor size, and restore gonadal function for patients harboring symptomatic prolactin-secreting microadenomas or macroadenomas. We recommend using cabergoline in preference to other dopamine agonists because it has higher efficacy in normalizing prolactin levels, as well as a higher frequency of pituitary tumor shrinkage. We suggest that clinicians not treat asymptomatic patients harboring macroprolactinomas with dopamine agonists. We suggest treatment with a dopamine agonist or oral contraceptives in patients with microadenomas who have amenorrhea. We suggest that with careful clinical and biochemical follow-up therapy may be tapered and perhaps discontinued in patients who have been treated with dopamine agonists for at least 2 years, who no longer have elevated serum prolactin, and who have no visible tumor remnant on MRI. Treatment of prolactinomas. Aims of therapy. Microprolactinomas. Restoration of gonadal function. Macroprolactinomas. Reduction in tumor size with improvement/resolution of pressure effects, particularly visual disturbances, and prevention of tumor expansion. Restoration of gonadal function. Although microprolactinomas may expand in size without treatment, the vast majority do not. Therefore, although restoration of gonadal function is usually achieved by lowering PRL levels, ensuring adequate sex hormone replacement is an alternative if the tumor is monitored in size. Macroprolactinomas, however, will continue to expand and lead to pressure effects. Definitive treatment of the tumor is therefore usually necessary. Drug therapy. Dopamine agonist treatment leads to suppression of PRL in most patients, with 2 degrees effects of normalization of gonadal function and termination of galactorrhea. Tumor shrinkage occurs at a variable rate, from 24H to 6 to 12 months, and extent and must be carefully monitored. Continued shrinkage may occur for years. Slow chiasmal decompression will correct visual field defect in the majority of patients, and immediate surgical decompression is not necessary. Lack of improvement of visual fields, despite tumor shrinkage, makes improvement with surgery unlikely. Apart from improved gonadal function, hypopituitarism present at presentation does not usually improve, and therefore replacement with, for example, GH can commence. Cabergoline is more effective in normalization of PRL in microprolactinoma, 83%, compared with 59% on bromocriptine, with fewer side effects than bromocriptine. Side effects of cabergoline include psychological.
Although cabergoline in higher doses, used for Parkinson's disease, can cause right-sided cardiac fibrosis, there is no evidence for this using the lower doses necessary for control of PRL levels. Dopamine agonist resistance may occur when there are reduced numbers of D2 receptors. Tumor enlargement following initial shrinkage on treatment is usually due to non-compliance. A rare possibility, however, is 2 degrees resistance or malignant transformation. In patients with psychosis and macroprolactinoma, estrogens and surgery should be considered. Higher doses of dopamine agonists may be needed. And aripiprazole with less blocking of D2 receptors should be considered. Careful monitoring is essential.
Dopamine agonists and impulse control disorders include pathological hypersexuality, compulsive shopping, compulsive eating, pathological gambling. Prevalence 17%. Hypersexuality commonest and commoner in men. Estrogens. Estrogen replacement, rather than dopamine agonist therapy, may be appropriate in female signed with idiopathic hyperprolactinemia or microprolactinomas, where fertility and galactorrhea are not issues. Small short-term series suggest no evidence of tumor enlargement with the commonly used doses of estrogens. However, monitoring of PRL is important. Surgery. Since the introduction of dopamine agonist treatment, transphenydoidal surgery is indicated only for patients who are resistant to or intolerant of Dopamine agonist treatment. The cure rate for macroprolactinomas treated with surgery is poor, 30%, and therefore, drug treatment is first line in tumors of all size. Occasionally, surgery may be required for patients with CSF leak 2 degrees to an invasive macroprolactinoma. Cure rates for microprolactinomas treated with surgery are greater than 80%, but the risk of hypopituitarism and recurrence of hyperprolactinemia currently makes this a second-line option. Bromocriptine given for 1 month may make the tumor fibrous. Surgical management of a CSF leak can be very difficult in patients with very invasive tumors. Tumor shrinkage with dopamine agonists will either precipitate or worsen the leak, with a subsequent risk of meningitis. There is no evidence for the long-term use of prophylactic antibiotics in this group. Radiotherapy. Standard pituitary irradiation leads to slow reduction over years of PRL in the majority of patients. While waiting for radiotherapy to be effective, dopamine agonist therapy is continued but should be withdrawn on an annual basis at least to assess if it is still required. Radiotherapy is not indicated in the management of patients with macroprolactinomas. It is useful in the treatment of macroprolactinomas once the tumor has been shrunken away from the chiasm, only if the tumor is resistant. Cabergoline and cardiac valvulopathy. Cabergoline, but not bromocriptine, is a 5-hydroxytryptamine 2B, 5 HT2B receptor agonist. High doses of cabergoline, e.g. 3 mg per day for greater than or equal to 6 months in Parkinson's patients, have been associated with valvular heart disease, aortic, mitral, and tricuspid regurgitations via a 5-HT2B target effect. The risk of cardiac valvulopathy appears to be low in prolactinoma patients on standard doses of cabergoline, less than 2 mg per week. All patients should undergo echocardiography before commencing a dopamine agonist. Patients taking a dose of cabergoline of less than or equal to 2 mg per weekly should undergo surveillance echocardiography at 5 years of therapy, whereas those on greater than 2 mg per weekly should have annual echocardiography. Dopamine agonist resistance. Definition: failure to normalize PRL. Failure to decrease tumor size to less than 50%. Occurs with 24% of those treated with bromocriptine, 13% with pergolide, and 11% with cabergoline. D2 receptors are reduced in number, but in not efficacy. Treatment options include switching dopamine agonist, increasing the dose of dopamine agonist, surgery, fertility treatment, or estrogen replacement, plus or minus pituitary radiotherapy, for macroprolactinomas. Temozolomide can be considered in aggressive/malignant prolactinomas.